All right, well, welcome to another episode of the JTaylor Healthcare Podcast. We're here live and in studio. Isn't this great, Herd?
This is so cool. We have our homemade podcast studio.
Yeah, we just Jimmy rigged it, and it's going to be great.
We're jumping right in.
Okay, so this is our big year in review. Herd and I, you guys see us, Herd and I, always on our podcast. But we brought in the ringer, Anna Brewer. Anna, how you doing?
Great. Thanks for having me.
Okay, and then always we love having Blake and Clete Madden. Blake with hospitality, Clete, longtime dear friend for 35 years, great mind in healthcare. And so we thought we would reflect on 25 and prognosticate towards 26. So that is what we hope to do in the next little bit of time. So before we get going, but Clete, why don't you introduce yourself and we'll just go around the order, do introductions.
Yeah, no, appreciate you having me again. Enjoyed last year. 35-year plus healthcare veteran, primarily focused started with KPMG, their healthcare practice, and then primarily focused in outpatient imaging. And just right now, currently helping a startup on some cardiac software technology, which is really innovative stuff, and just enjoying it.
Good. Glad to have you. Great to see you again. Anna?
Yeah, good to be here. I guess I've been at the firm 20 years now. This is my 20th anniversary. And before that, Ernst & Young and Arthur Anderson. So always good to start out at the big firm and get your feet wet there. I spend most of my time nowadays in some sort of a deal format, whether that is helping somebody sell a practice or helping somebody buy a ASC or something of that sort, and then do a lot of work around valuation as well for MSOs, MSAs, those sort of things that come with the transaction. So seeing a lot of deal volume, of course. So that's my background.
Awesome. Yeah, and I went the easier route. You guys are all valuation and consulting. So I'm a former consultant, burnt out and moved into, media and marketing. I guess technically I'm a healthcare creator. So I write a newsletter called Hospitality, covers the business of healthcare. And now we are, going into full podcast and community and kind of live events. So building out the full media ecosystem, and recently reached 50,000 subscribers. So that's a cool number.
So
I like to joke it's about half of DKR, which is Texas football stadium. So the goal is to get to 100K and change. So we're halfway there.
Fill the stadium, right?
That's right.
That's what you want to do.
And your grandson, your 2-year-old grandson, kept him up all night, so you may need to kick him a little bit
All right.
during this thing. So just so you know. So,
yeah.
Herd, what about you?
Oh, yeah, I'm the co-host of the JTaylor podcast, right? So partner JTaylor, been here almost 20 years. I think it'll be 18 years this year, and focused a lot valuation. Did a lot with ASCs last year, a lot with urgent care, just a lot happening there. Similar to Anna, just if there's a deal, we're in some place on that, and then do a lot of managed care analysis. And so we've really gotten into price transparency and using that data to help our clients, help with valuation work, but also help with benchmarking contracts and figure out potential revenue opportunities. So spent a lot of time in that last year. Yeah.
Well, what I think we'll get through today is a list of things that have happened in 25 and we expect more to occur in 26. I first of all want to start out with an apology, Blake, to you. Last year when we did our year in review podcast, I think Herd, you and I kind of went through the top 10. And then Blake's like, excuse me.
You're missing something.
You didn't talk about GLP-1s or the specialty pharmaceutical market. And I think that's going to be a big deal. So I apologize, Blake. You were so right. And I was so...
Well, that's why he has 50,000 subscribers. And we don't.
That's right. But anyway, so we'll talk about that a little bit today, too. So one thing that I wanted to start off with, a little bit of a roundtable, is just this idea of disruption and a miss in value. And so the idea is that, and I listened to the advisory board, which is fantastic, and they talked about this concept of sprawling advisors and misses in value as far as we have rising costs and declining reimbursements. And there's just a lot of things happening in the healthcare ecosystem where we're just missing a little bit. And so I'm just curious, and Herd, why don't we start out with you and kind of go around about what are some of the changes that are occurring because of this disruption or just a miss in value that the traditional healthcare system's not providing?
Yeah, and really, we were talking before the podcast. We're 16 years into the Affordable Care Act, or Obamacare, and you can see in the data, for the first 5-6 years, we didn't bend the cost curve down like it was, like President Obama said, but it certainly slowed the rate of growth, and we the healthcare was about 17-18% of GDP, and it kind of held steady there for a few years once it happened. But now we're at a place where, COVID, it spiked back up and it went down a little bit, but we're kind of see healthcare costs going back up. You have the Affordable Care Act subsidy issue that's going on right now. And I think you're really going to start seeing healthcare as an electoral issue coming up. Right. And I think a lot of it is you've got a lot of entrenched, players in the market. They've adapted to the Affordable Care Act over the last few years. I mean, that's what's driven so much of the M&A activity that we've seen. But we're going to have this issue going on with costs. And so now we're at a place where technology and AI has been going. We've been saying this for a few years that it's going to happen. Well, it's really going to happen right now in terms of AI and the way that technology is going. And you got a consumer that is not happy with the product. And so you've got a lot of people out there who are trying to make changes and trying to do different things.
And meet consumer needs.
Yeah, meet consumer needs.
Right.
The issue is always financing. I mean, we had the whole retailization idea that we talked about a few years ago, and how that, it really kind of hit the headwinds of economics. It was what caused that. But something's going to happen. And I know with hospitality, with technology, you talk about that all the time, all the different players that are out there. And so you just have a lot of players out there trying to do something with this new technology, trying to disrupt things. And I think the big entrenched health systems, big entrenched players are going to have to react to that somehow. So I think there's a lot of forces gathering that are going to force some kind of change. Yeah. I don't know exactly what that'll look like, because we still run into the financing issue that's always there. That's right. And we'll talk about that in a little bit. But yeah, that's kind of what I see.
Blake, what do you think?
Yeah, I mean, Herd, to expand on that point, I think that, as what you said as well, there's a ton of friction in healthcare right now. And what I think is kind of playing out, maybe slowly, but maybe, all at once as well, is this convergence of, AI and consumerism, and you got, the price transparency and, lack of trust in healthcare. Trust is decreasing, especially post-pandemic. Yes. All these various groups are kind of trying to find their own tribe, right? Whoever the wellness expert, the med spa, or, the doctor, or whoever AI. And, as this is kind of playing out, that these consumers are actually, consuming healthcare and wanting more choice. And that is like completely at odds with the current infrastructure and setup of today's healthcare system, where you have to go through insurance. You don't know the price. Even the doctor's the gatekeeper, right? And so consumers in general, I think, are smart and savvy. Like, we all know what we want. We go on Amazon or those sorts of things. So and through rose-colored glasses, I would like to see a future where that is, the level of consumerism we see in healthcare too, is, the price and you are able to navigate. And I do think we're seeing elements of that pop up in various aspects of healthcare. Now, will we get there fully? I don't think so. Like, there are just structurally certain parts of healthcare that are just not set up for consumerism. But there is an increasing kind of, river of things that are. Right. And so that's what I'm excited about, what I see as kind of the convergence.
And not to throw a wrench, but what are some of those pieces within healthcare that are not set up to accommodate consumerism?
The entire billing process in healthcare.
Exactly.
No, I totally agree. I think there's I am still pinning my hopes on price transparency, because I feel like until we really get to the point where everybody can talk about a specific dollar amount for a specific service, we can't really transform. And I think the point of price transparency was always to have the consumer have a say. I'm not sure we're there. I'm not sure we're going to be there anytime soon, due to various reasons, but also just the usability of the data. I know I've been in healthcare for a long time. I can't use it very well, right? Even just the format of the files are not for a consumer. No. But it is still insurance companies calling the shots on where you get your care. Clete can probably speak to this more than I can, but for a startup company who is trying to introduce themselves to the market, there is an automatic gatekeeper, even if it's a better service and even if it's significantly cheaper,
Right.
because they're not in network to do XYZ.
No.
And so I still think we've got a mismatch in there. And I think a lot of it is probably at the feet of insurance companies to try to find the next disruptor and allow that disruptor to truly disrupt as opposed to keep them out. And so I'd love to see more of that, but I still think price transparency, I hope, is the way forward.
Yeah.
To have some sort of transformation there.
Right. Got it. Clete, what do you think?
When I got your email about doing this again this year, I just really thought, we talk about being in this business for 30 plus years, and it seems like we've talking about a lot of the same stuff.
We are.
So I'm sitting there going, okay, should we really just get back to, how was this country built? It was built on capitalism. It was built on competition.
Right.
It was built on who's got the better mousetrap. So do you focus on that? And really, everything that I've seen and we talk about is you follow the dollar. So I may just be out there on some of these things I'm about to say, but what I just said, keeping that in context. Well, why don't you do something like, what if you have a state by state competition? And so the state that builds the better mousetrap gets more federal dollars with incentive. And why the prohibition on not having physicians investing in certain things? Well, why not?
Right.
If they do it better, let the marketplace decide. Because we're not getting there right now with where we need to be.
Yeah.
And 20% of GDP, that's insane. And most of that is just, probably 15% of that, 14% is administrative costs.
That's right.
And require the states to have a preventative aspect. And it's, I don't know. I just think it's all out there. All the information, the data is out there. We're just not executing on it.
No, I agree. And
Well, let me interject real quick on the point about state by state competition. I will be really interested to see how kind of the rural health dollars get dispersed, because as I understand, that's part of it. Like half of it is like kind of equal distribution or something, which in and of itself is controversial. But the other half, I think, or 25%, is based on what models are you proposing and those sorts of things. So that will be an interesting kind of case study.
Let's pivot over to that. Sorry, Herd. I'm gonna go to the one big beautiful bill now,
Sure.
as opposed to AI. I want to hit AI.
Oh, come on.
Sorry, dude.
We'll get there.
We'll get
Steal
to
my
AI
thunder.
next, but with Presidents Trump, ABBA, whatever we want to call it, one big beautiful bill act. What are going to be the major implications? Because in 26, we're going to see the fruition of that act come to reality. What are we expecting? Because when I talk to hospital CEOs, they're like, "Oh boy, I'm going to have major Medicaid dollars that are coming away from me, and I've got to figure this out."
Yeah, I mean, the biggest prediction, and it's all a prediction right now because no one really knows, is you're going to have a significant increase in uninsured population, mainly because with the Affordable Care Act, keep talking about that, there's new provisions that require, instead of auto enrollment, you got to re-enroll every year. So there's kind of there's more friction. It's almost kind of creating more friction. You got to re-enroll and you got to make yourself eligible for that. So they're worried that you're going to have people opting out of it. They're also shortening the enrollment period a little bit. And then the big one in the news is just the subsidies. So there was, premium subsidies that were passed during COVID. They were supposed to be temporary, but people, they have them and they're going to expire. And this is why the whole government shutdown occurred last fall, was the expiration of those subsidies. Now, I don't think they're going to fully expire because that's an issue that Congress is going to have to handle at some point. So but that's kind of in the air. And then on Medicaid, they're basically increasing a work requirement, and you have to be looking for a job. There's certain things you have to be doing in order to qualify for Medicaid, and there's other eligibility items with Medicaid that are part of that. And so as the bill was written, if the ACA changes happen and the premiums, the subsidies expire, and if the Medicare, all the changes that they have there, they think there could be 16, 17 million people more uninsured. So an increase in uninsured population by about 16, 17 million.
Yeah.
So that's that's a big thing that hospitals have to deal with. I was kind of looking at some stats before we came in, and 44% of all hospital revenue comes from Medicare and Medicaid. It looks like about 19 or 20% comes from Medicaid. So this is real issue is you have this population, and so anything that impacts the number of people on Medicaid is going to impact hospitals and impact their revenue.
That's right.
And so that's just that has to be dealt with.
As we've talked about for a long time, Medicaid generally, you're not going to make money on Medicaid, at least in the hospital setting. But at least it's something. It's better than zero, right?
Sure. I mean, it's covering your fixed costs. I mean, it helps cover costs, and Medicare, you kind of break even on, you lose money on Medicaid, and then you make your profits on the commercial business is sort of the way it works.
So I've talked about with safety net hospital leaders, they are significantly worried about, hundreds of millions of dollars of funding that they're not going to have access to.
Sure. And I mean, we talk about, 19 or 20% Medicaid for hospitals. I mean, that's a national number. So if you drill down and we mentioned rural hospitals, and some rural hospitals is 30, 40%.
That's right.
And so, anything that happens there is going to affect them. So I think that's just a real issue to deal with. And back to some of the, response to consumerism, response to things. I mean, this is one of those structural elements that if you have 44% of the buyer of this service or the financer of the service is a government program, it's going to impact it limits the ability of people to respond because those prices are set in a much different way than a consumer price is set. Right. And so it's just, it's one of those structural elements that make healthcare complicated and make it why we're talking about the same issues 20, 25 years later. We still have a lot of the same things we're talking about.
Yeah.
There's a downstream issue from the bill that a lot of our hospital clients are calling us about right now, and that is if you take people out of Medicaid, then you have less SSI days, which then influences your DISH percentage and then your 340B percentage. Mm-hmm. And a lot of our hospital clients right now are making money out of the cancer side of the house in pharmacy. Mm-hmm. Those days will be removed. Presumably. There's lawsuits and injunctions occurring right now in Texas over that. But I think that's going to be an interesting downstream piece of it because although our hospital clients have not quote unquote made money on Medicaid, they kind of are in a secondary fashion because it impacts the pricing that they can get on all infusion for their cancer program, which has become now the orthopedic and cardiology and radiology service line in years past. It's now cancer and oncology that's moving the needle on margin. So I think it's an interesting, it's a secondary piece that's not.
That's right.
But our clients are calling. Yeah. They're calling right now.
Right. One more downstream interesting piece of that is, that kind of pocket of people who are on those enhanced subsidies who are like, relatively speaking, well off, right? And maybe they're on high deductible plans, they have HSAs. Those, however many 5 million or so people, plus like the uninsured population, some of them will go to get jobs and those sorts of things. But also I'm curious, like what I want to figure out is, are we kind of setting up the petri dish for a cash pay kind of system to emerge and whether, to your point about billing, like will hospitals, will providers or, D2C telehealth or whoever it is set up, these cash pay mechanisms and say, hey, let's cut out insurance, to Mark Cuban's point and say, let's cut this out, lower our admin overhead by 20%, our days to collect, and go direct and those sorts of things. So I'm thinking like maybe there's some rumblings of like that kind of parallel health system emerging.
Yeah.
Well, everything's connected.
Interesting.
So you think about the primary care docs that have been moving towards concierge medicine. You've got this cash pay option to fill another void. So it just goes back to the disruption. There are going to be things that pop in that fill a void, and I think you're right.
So what if Medicare patient, and this is off the wall, but what if whatever the number is, we tell every Medicare patient, no insurance, we're just going to give you $5,000 a year, and then we'll devise for catastrophic, we'll set up like reinsurance or something. we'll do something on that case, but you got 5,000 or 10,000, whatever the number is, and you have to manage your health care with those dollars. So we're going to give you manage, hopefully that changes behavior, and we'll have a catastrophic thing on the end, but you've got to go to this make this preventative study. You got to follow this particular diet for 5 out of 7 days a week. I don't know. I'm just making this up, but I'm just thinking this again, changing behavior and it's the incentives just need to be flipped.
Right.
I think the fundamental question you're getting at is like, what is the role of insurance really, right? Like what should it fundamentally do? Like, should it function like car insurance where if you're a worse driver, and those sorts of things and it's catastrophic and whatever, versus like how much should you, take control of your own health and, maybe set up some sort of like expanded HSA function where it's like, hey, either employer or government will give you X amount of dollars and you just do what you want with it. And if you're healthy, you pocket it, like those sorts of things. But then, the whole insurance model is, the young people subsidize the old and pay taxes. And so, there's a whole kind of just policy world that I'm not smart enough to get into.
I love talking about people to have a wearable and that their data goes in so you can track them. Like, State Farm's got this thing you put on your car. So they track your stuff and then you get
a safer driver. Better
exactly.
rates.
So what if like as a patient, you could opt in to like provide your data or whatever, right? And I know that's such a touchy subject with HIPAA and all those sorts of things, but if you were able to kind of, I don't know, that's kind of big brothery too in a way, but I don't know. I think about that sometimes. Just
let me make the big pivot over to AI because in my mind, the payers are jumping in. Like one of your pieces lately, you just talked about how the big push is going to be for payers to go in and really around plan design, authorization, those two in particular. That may get to Clete's point of how am I going to modify behaviors? I'm going to modify them based on your plan design of which, within Medicare Advantage or a commercial product, you will or will not be able to do that. Otherwise, you're going to pay for that.
Right.
And so with AI, I think last year it was this kind of pie in the sky. Hey, we all use ChatGPT. It's very cool and interesting. And everybody's talking about it, but nobody knows what to do. Now we're getting into a different realm. And so let's go down the path of payers and providers of what both of those in your mind you're thinking they're going to do.
Yeah, well, to your point, I think if we went around the room, even here, 2 years ago versus today, we're using AI drastically differently. Even just personally, professionally, you guys are probably, making slide decks or putting outlines together, like those sorts of things. Mm-hmm. Same thing is happening with payers. They're responding to their customers' needs. Employers are asking for more flexible benefits design and those sorts of things. And I think, United is seeing traction with things like that. But other than that, there was a Wall Street Journal article that came out that said, United Health Group has identified 1,000 plus use cases for AI. Right. And it makes sense, given their scale, like 0.1 basis point is, X number of dollars, right? And their primary needle is in the admin side and then less so the medical side. I think that we're going to see more shift into the medical side as things go along. But yeah, one of their biggest levers today is, the prior auth and holding on to that cash as much as they can in the reserve and those sorts of things. And again, I'm not like an insurance expert, but you can just imagine like all of these various, they've bought all of these assets. They have all of these members across all of these, disparate markets. How can you start to piece those together, use AI really to drill down into, better insights into those populations and, subcontract and actually identify who's a quality provider or, how can I, optimize coding on this Medicare Advantage patient or how can I tell who's upcoding me, those types of things.
Right.
And so that is going to converge with the provider side, right, of saying, hey, okay, I'm a hospital system. How can I, bring patients in, increase my throughput, those sorts of things. A lot of those are administrative functions that AI can help with. And then also, how can I document better, right? Ambient documentation. How can I feed that into revenue cycle functions, EHR functions, those sorts of things, and then optimize billing, and that's all administrative functions. And, the things that I'm more excited to learn about are how are how is AI being used to move the needle clinically, right? So how is insurance thinking about lowering their MLR through like clinical partnerships or whatever that looks like providing certain tech or those sorts of things, not just like moving a prior auth lever.
Right.
And on the hospital side, how can you decrease length of stay by, proactively reaching out to patients or, increasing ED throughput through some sort of clinical workflow or, whatever the use case is. I'm very excited and interested in the medical and clinical side of things.
Yeah.
If that makes sense.
Well, what I've heard from controllers and CFOs in particular is about the show me the return on investment for that.
Mm-hmm.
The other thing that I'm excited about that I don't know it'll be at 26, but over the next 4 or 5 years is kind of groups of AI applications being governed by other AI, more of a systemic view. So when you think about the ERP systems and HR and supply chain and IT management, overall management of your provider or whatever platform, there are all these uses and none of them are integrated yet. And so the idea would be, I think, in the next couple of years, we're going to see way more of that, especially in the ERP administrative systems, be able to pull all that together and have a much more consistent approach. The EMRs are Epic and Cerner and the others. They're all kind of going to be in the game too with analytics to show effectiveness of this clinical utilization. They're going to be doing that.
I will say, if you're a provider and you're not keeping pace with the payers on AI, because for example, so again, I mentioned this cardiac software we've got. It's got CPT codes, FDA approved. It's superior to stress echo.
Right.
And we're going in and hired some reimbursement consultants and said, okay, for what we're doing, it's a better mousetrap. It's quicker, the whole 9 yards.
Mm-hmm.
And we think we should code it this way and get this reimbursement. And they said, these payers now with the AI, they're going to kick that out initially. Yeah. They're going to go back to this. It's experimental, and which we've got arguments for, but the AI is initially for them is going to kick it out. So you need to get ahead of that. And that's just a minor example.
Yeah, so it goes back to Anna's point of what's a disruptor? Well, the buck stops with financing healthcare right now.
And if the insurance companies are using AI to decline it, then we're not going to get the disruptor, which may be superior care.
That's right.
Yeah.
That's right.
Yeah, but insurance companies are facing a kind of an existential branding crisis. I think that their power is kind of waning in the public eye as far as policy and the kind of AI-driven denials and those sorts of things. So I wonder if that's going to kind of come to a head soon. I don't know. It's just a very delicate situation, especially with kind of the, what happens at the end of, was it last year, a couple years ago with the murder and those sorts of things.
Yeah.
I feel like since then, public perception of insurance in general is terrible, but especially now has decreased since then.
Well, I agree. However, I would follow Clete's advice on follow the dollar, and the dollar goes through the payers for the most part. A little bit of an off topic is a lot of our big health system clients are doing very unique things with going after clinically integrated networks or direct to employer contracting or things of that nature. They're just being very creative on how can I skirt the system? How can I get away from this payer relationship so that I can go directly to get a book of business through large employers or a clinically integrated network and have buckets of providers together to have a much stronger play to go against the payers.
So to contextualize that, at the end of 2025, Northwell Health announced a partnership with a union. Can't remember the name of it, but basically they said, hey, we're passing through all admin costs. And for that reason, we're able to cut healthcare costs by 20% in year one.
Right.
Or maybe it was admin costs purely, but something, a huge cost.
Tremendous,
which, I imagine that's a huge delta as far as dollars are concerned.
That's right. That's right. Let's pivot over to investments and M&A. Anna, I'll start with you. And just what are your thoughts? You kind of reflect on 25 a little bit and prognosticate out to 26 on kind of the M&A world and what you think is hot, what's not, and what you think is going to continue to roll.
Yeah. So things are still moving from a deal perspective. interest rates have sort of stabilized. So for a while there, they were so high and people were worried that they would come down at a later point in time. So the cost of capital was too high to get deals done. That has pulled off some. And I think either folks have realized this is still a pretty good cost of capital in the grand scheme of a 50-year run. It's still a good cost of capital.
Right.
And not the best it ever was, like 2020 and 21. But some of that's gone on. And also I think there's just been a stabilization and still too much cash on the sidelines. So there are still deals occurring. ASC is still hot, and I see that continuing out into the future, mainly because it makes sense from every angle.
Mm-hmm.
There's very little downside in my mind to it. So maybe the downside is from the hospital side if they haven't gotten in the game, but the payers are still very appreciative to have somebody move to an ASC as opposed to a hospital. Physicians
Look at
are
Tenet's stock price when they
Yes.
finally fully absorbed USPI, and then Ascension is copying them.
right.
Yeah, to your point.
Yeah. When hospitals get involved, it becomes a win-win for everybody. But I think it's good for all the parties at this point. I think the physicians are still doing well with it, and I think that it's a good play for them to invest in something other than their professional fees. And I think patients are happy with it from a retail perspective. It's better than walking into a large system and being bumped out of the main OR.
Right.
So I think it's still the right play over the long term is the ASC approach. For sure, those that have the best managed care rates and those that have done deals with hospitals, because generally that gets you a good managed care rate,
Yeah.
are the ones that are winning.
Right.
And so we're seeing a ton of work around that still. I'm always surprised there's still independent ASCs to be had out there, but there are.
Yeah.
So we're still seeing those deals, and then we're seeing them trade between each other, which is really interesting work.
Similar push in the imaging space.
Yeah.
Especially with the hospital joint venture, which years ago you didn't really bring that up. Now on especially the publicly traded, we'll mention that as a key strategy now.
Mm-hmm.
It is interesting, though. One of the chief development officers for one of the big ASC outfits told me, he said, the easy deals are done. Now we have to go get the hard ones.
It's the hard stuff
So
as
the
well.
de novos
It's a
and
good
kind of
soundbite.
kind of
Yeah.
hard
Maybe
ones.
true. Yeah, maybe
So,
true.
yeah.
We're still seeing deals, but yeah, that's
Oh, yeah.
probably right.
Right.
So physician-wise, I'm seeing less interest in the physician space than there was a couple of years ago, and I think the main reason for that is those are just really hard deals.
Mm-hmm.
They tend to be done with physicians who have run practices for a long period of time and controlled their own destiny,
Mm-hmm.
and you're asking them to lay that down.
Right.
And as much as they say, I'm willing to lay it down for a large check, it's hard to lay it down.
Right.
And so behavior changes. It's healthcare, but it's really healthcare and finance and psychology, and that intersection's hard.
It's the psychology piece, right?
Yeah,
I mean,
it's hard
yes.
to get people to still do the same thing, but they don't have as much upside in it. So,
Right.
And another thing I see in those deals, which I find is really interesting, is that initially they're all stars in the eyes with respect to they get their cash, but they're going to get some equity.
Mhm.
And as you get down the road, even several months down the road, maybe years, those physicians don't care about the equity.
Right.
It's just cash.
Yeah.
It's just cash, and you've bitten into their cash stream, and they say, "Well, we need more cash now," and said, "We paid you. We paid you."
Right.
And so
at a discounted rate, right? So that's where the valuation comes in, and it's a discounted net cash flow, and it is
earnings
discounted.
stream.
That's the key. So we're seeing some interesting stuff on that. There's still deals out there. A lot of them, I think, are more appropriate deals, more curated deals than what I've seen previously. Before, it was everybody's for sale and everybody's a good deal, which of course is not true. Now we're seeing some specialties that have enough ancillary that you don't have to cut into as much of what the physician is making.
that's key.
And I think that's where the plays work.
Yeah.
And so we're seeing a lot in the cancer space. That's
Right.
where a lot is occurring right now. And then the subspecialties that are doing the diagnosing of cancer.
Right.
So that means urology, GI, breast surgery. Those are where some interesting things are occurring right now,
Good.
because there's enough ancillary around it for it to work. And then it feeds into the bigger play of the cancer network. And again, the drug companies now are the owners of some of the largest cancer entities in the US. And so all of that is lining up right. So we're seeing that. And I think that will continue because, again, the alignment's clean, so clean.
Mm-hmm.
on that piece. And so I think there will be some physician deals that occur in this next year. Again, there's just a lot of momentum in that subspecialty cancer care and diagnosis of cancer.
But if you get on X or Twitter or whatever you want to call it, if you just take ivermectin, you can just take out the oncology line of business.
There you go, folks. Medical advice from
Yeah. Now, Clete, what do you think about the investment world from private equity? Though there still seems to be a tremendous amount of kind of quote, dry powder and a lot of interest. What do you think about that?
Well, very, very similar to Anna's comments there. If you look at some of the private equities that I have some access to, like Wells Carson and some of the others, the physician deals are not drawing their powder.
Mm-hmm.
A lot more IT based,
AI-enabled technologies.
Some cybersecurity,
Right.
Which, by the way, is a big one of the biggest hurdles now as far as getting deals done.
Yeah.
Because you got to make sure if you're bringing in somebody into your operation, you can't let them infect your system and that sort of thing. But
That's right.
But very much in lockstep with your comments with private equity is where they're going.
Yeah. Okay.
Some pharmacy stuff too. Drugs.
So we expect a pretty hot 26, right?
Yeah, and I'm still bullish on the large group who's buying another large group that doesn't have private equity involved. I still think there's a ton of sense in that.
Well, I think you're starting to see a lot of that. You're seeing the private equity model, like it works well in some spaces. Some places it's been a lot more challenging.
Yeah.
And so then you're seeing alternatives pop up. And so you're seeing, okay, well, we want to be independent. We don't want to be employed. Private equity, again, if the margin is created from reducing your salary and basically coming out of your labor, a lot of people are like, so then
we don't have to do that.
Right.
How do we work together without cutting comp?
Right.
Yeah.
Exactly.
Yeah.
Right.
And then you've seen lots of success, the primary care enablement models. I mean, that's where you have seen success with Privia and other companies like that, where it's like you still maintain some control, you get some benefits of scale, you get some benefits of, cost sharing, some benefits there, but you still own your assets, you still have control, and you kind of can be a master of your own fate a little bit more. And so I think you're seeing all those that are still going to be out there.
What'll be interesting is where private equity plays potentially in more in mental health, behavioral health, and also longevity type of space.
Right.
But again, it's what ancillaries does that have? What technical aspect does that have? Because you just can't rely just on the pro fee.
Yeah.
Well, you follow the money, right? Like if you think about longevity, where's the money? GLP-1s.
Yeah.
I don't know about you guys, but there's like a med spa in every corner I see popping up. And there's wraparound services around that you can provide to enable that. So I think the answer is in front of us when it comes to stuff like that.
And what's interesting, this will get a little off track, is that, you have this wealth gap, this longevity, they're figuring out all this stuff you should do, but it's mainly focused on the more affluent, but all this data they have, God, what if it's pie in the sky? What if you applied that just to the general populace of all this information and again got back to preventative screening and that sort of thing? It's easier said than done, but
That's right.
God, there's just so much out there that we're not actually.
Well,
I was listening. Oh, go ahead.
Well, I was just going to flip over to the specialty drugs.
Yeah.
The GLP-1, and I do want to talk about 340B as well, because there are some implications on that side too. But GLP-1, my story of the year was this. I was doing this one hospital buying another hospital, and a historical, really profitable service line was bariatric surgery. And they said, hey, Kyle, go and put all the 5-year projections on bariatric surgery. And it went from significant revenue, significant margin to zero. Matter of fact, it was a cost suck, because if you had any resources toward that, there was none, because it was just like, well, just go get on your GLP-1 shots and you're good. Now, I'm not giving medical advice, but it is a foundational change.
America loves drugs, don't they?
Yeah, right.
Though, I've got a client who's trying to flip that script right now and is saying GLP-1 helps you get to a bariatric surgery faster. It's a part of the weight loss medication and the weight loss that occurs that can actually create a long-term play. I don't know.
Yeah.
I think it's an interesting value proposition.
We talked about last year, we talked about 66% of the population in America is obese or morbidly obese. We have a giant population that's getting gianter. And so GLP-1 is a great, hey, take a drug and let's fix it. But it's been fundamental this year. In 25, we've seen major changes as a result of that.
And from what I understand, like the definition for obesity is changing as well, like how you define obesity, like BMI, that might not be the best measure, like things like that. And then, sorry, can you bring up your point one more time, what you just said?
Just that GLP-1s actually can now be a way to get individuals certified for a bariatric surgery.
Yes.
So it can actually get them to, I mean, the hope would be, who knows, the hope would be that you get the bariatric surgery and then don't have to be on GLP-1s for the rest of your life.
Yeah, and kind of like a continuation of that point is, I mean, I've been talking to some health system folks and this kind of like slightly contrarian perspective where the traditional thinking is, hey, GLP-1s, if taken long-term, will like reduce costs and those sorts of things, which I think I generally agree with. But kind of in the short term is that same effect where it gets people to a healthy weight or like the right weight to be eligible for certain surgeries like joint replacement or whatever it is. And it's lower risk. And so that actually increases surgical demand, at least in the short term. Now, long-term, I don't know. But I think there's a lot at play here with GLP-1s. It's very
could hospitals use that as a approach to
like just a little weight management program?
Yes, to secure volume.
Yeah,
it's interesting.
Yeah, very interesting.
So back to the specialty drugs. That is clearly going to continue because we're seeing major margins out of that, right?
Well, I mean, you look at the trajectory. It's like 8 to 10 to 12% a year growth in specialty drugs, right? And so it's interesting because, we're talking about like the drug distributor vertical integration. So like the McKessons and the Syncoras of the world with OneOncology and so forth. But that is essentially, it's sort of a response to both hospital and health system vertical integration with those assets, but also insurance activity where, they have the PBM and utilization management, and they're buying their own infusion centers, and they're also trying to set up their own vertical integration as far as manufacturing biosimilars.
Right.
And so from a drug distributor's perspective, they're sort of getting their hand forced. Like they kind of need to buy these practices. One, because it's economically viable and a good acquisition for them because they can lock these physician practices in areas of high specialty drug spend growth, brand name drugs, whatever, rebate, those sorts of things for like a 30-year contract. But also they can, circumvent the insurer and the kind of biosimilar kind of thing going on and have that economic profile locked in over a long period of time. So, and then all of that is counter to any sort of value-based care initiative, right? Because all of that incentivizes cost going up, the brand name drug, rebate.
Well, if you want to really go vertical, then they should just buy these food companies and actually put non-processed products out there and healthy products out there. Again, garbage in, garbage out.
Yeah.
Anyway,
Well, let's get back to
the
the 340B because we've talked about the One Big Beautiful Act, how that's going to impact things, how relationships are changing because of the profitability of 340B. Now, downstream Medicaid days may come off, so some of the changes to 340B. Anna, what's your thought on just overall 340B in 26?
I don't know. It feels very up in the air, but I think it's more consequential than it ever was.
Very mature answer.
A lot of health systems have a lot of dollars and a lot of margin wrapped up in 340B right now.
Right.
A lot.
Right.
Again, it feels like it's more akin to what radiology used to be 20, 30 years ago for a hospital system as far as the driver of margin. And maybe it's kind of like orthopedic and cardiology services as far as where you would put your resources, because it's been an interesting place where folks have been able to make money if they have alignment with regards to the infusion itself.
I see.
And so that's non-cancer infusions and the cancer infusions. And so, 340B was not built for that intentional purpose at all. But it does appear to be driving deals right now that we're seeing, and driving market share and who's employed by whom and where the services take place. And interestingly, this is maybe one of the only places where the hospital might be a cheaper place than elsewhere, because they have access to these drugs at such a large discount.
Right.
And so I think that's an interesting situation. So, but I don't know what the administration and Congress is going to do with 340B. Is it doing what it was intended? Is it reducing the cost? I don't know.
I think the issue in Congress that you're seeing right now, and actually I read an editorial, Wall Street Journal, earlier last year, I guess late last year, about, the 340B program was intended to be kind of a small program that, that gave cancer care and drugs to rural hospitals, smaller hospitals, and basically help fill a gap from a piece of standpoint there. But then it expanded, like everything else expanded. Hospitals are taking advantage of it. It's driving deals. It's doing, and so now it's kind of become this really, really big thing. And so kind of along with like site neutrality that we haven't really talked about, but you see a lot of issue there. You hear bubblings in Congress, like it wasn't supposed to be this big. They're not supposed to be making this much money off of it. We need to do something about it. So that's sort of out there, but also like site neutrality, as we've seen, is there's a lot of, ideas on what you should do about it, but there's the money hospitals make off, enhanced from site neutrality, the money they make off cancer care and 340B pricing, that's funding losses in other places. So it's not as simple as like, we should just cut this off.
Yeah.
It's, if you cut that off, then you're going to have something over here. And that's kind of the problem, but it's certainly on the radar.
Yeah. And maybe strange bedfellows, because now maternity care and pediatric care is getting investment that it previously has not had.
Right. Exactly. That's my
but
point.
it's because they need to attract more SSI days, more Medicaid days in order to hit the 340B, in order to have the drug margin. It's such an interesting domino that if you don't watch where the funding policies are going, you wouldn't know why people want to expand their pediatric programs.
Interesting.
Let me hit on 3 also rans before we go around the horn and wrap it up. 3 also rans are one in behavioral health. We asked for more utilization over the last couple of years. We've seen that, and there's questions on, is it effective? And is it actually helping? So we're seeing more utilization, but questions about effectiveness. Number 2, strangely, that we didn't speak about it because the last couple of years we've talked about workforce as being the biggest issue, and we're not talking about that right now. So this seems like some stability there, even though there are real gaps and kind of a workforce gap as far as primary care providers and physicians and the retirement that's about to happen. All of that is about to happen. So I think that's still there. You and I have talked about that a lot over the past, and I still think it's still there. It's just, it's kind of not top 10 issues, unfortunately. And then the last kind of also ran issue is the convergence of Medicare Advantage and Medicare traditional enrollees is right at 34 million right now. And it's converged where we never would have thought that Medicare Advantage would be just as common as traditional. And we're seeing that now too. So those are 3 other issues that we really didn't have time to hit on, but I thought it was interesting. So now as we kind of round it out, I wanted to go around the horn and just get kind of final thoughts on what you think we should be looking at for 26. So Clete, let's start off with you.
Yeah, one thing, we talk about AI and nauseam, but I think all barrels or a lot of barrels of AI ought to be focused on just rooting out this healthcare fraud. And if you, based on the numbers I've seen, if you ferret it out just 10% of that, 20% of it, it'd be a significant number that would, help with the curve. And
right.
And then my second thing, this is a little off the wall, but I'll leave you with this: that a Harvard study just came out, and it's a pretty good cohort, and I don't remember how long the study was, but the conclusion was, what was the number one impact on longevity, successful longevity? It was where you stood when you were 50 years old with the status of the relationships in your life, and how healthy was that? So those people with the measured best relationships when they were 50 years old lived the longest.
Oh, man. Okay.
Fun fact.
Very interesting. Thank you. Anna, what are your thoughts for 26?
I'm going to put out there what I hope for instead of what I actually think will happen, in the hopes of getting some momentum towards some things, if that's okay. What I am hoping for is maybe more attention from the hospital world on physician funding. I think if you look at it now, the number one employer of physicians are hospitals.
Mm-hmm.
But the hospital lobby continues to not pay attention to the physician fee schedule.
Right.
And the economics with physicians is frankly untenable. The math doesn't math any longer.
No.
We get calls from hospitals who have a lot of physicians employed by them who are asking us, what are we doing wrong? And yes, there are some things that we can help with and strategies that we can employ. But part of this is that the physician fee schedule has dropped over the years, just year over year over year over year over year.
Right.
We've cut past bone, and I don't know what we're in now, but the math does not work.
Right.
So it creates a situation where the private practice physician, it's quite a difficult slog to make it work. So I think that means for me that I'm going to continue to see transactions occur until we stop that bleeding.
Right.
And I'm not sure that that's good for healthcare in the end. And I don't think it's good for my hospital clients either.
Right.
But until the AHA starts to care about the physician fee schedule piece, which turns out they're the biggest owner of physicians,
Right.
it's interesting that nobody's paying attention to that, or I don't think they are. I'd like to see that lobby take a look at maybe more reasonable funding between hospitals and physicians.
My PCP doesn't take Medicare.
Correct.
He's older than me.
Yeah,
Okay.
so there's a good resource, an AMA study that comes out every year. It's on the employment dynamics of that. And I've written about it a few times, but that trend is accelerating. So
Well, you're
more
seeing,
business for you.
we mentioned it briefly, but I mean, concierge medicine, direct primary care. I mean, it's a minuscule piece of the overall picture right now. But I have a friend who's a doctor, and I mean, she went direct primary care a few years ago, and like, this is great. I get to take care of patients. There's no paperwork. I charge reasonable rates, but we keep a lot more of the money, and so it works. So I think you're going to start seeing that, just a larger portion of people kind of opting out of the system if these things don't get fixed.
Yeah. Blake, 26 predictions?
Yeah, real quick on that. I've written about kind of like the stratification of primary care. I think that kind of accelerates. But something that I think is interesting beyond what we've already talked about with consumerism and kind of going direct and those sorts of things is I just think in general, AI and the technology is kind of commoditizing. And so when you read press releases or you see companies and what they're talking about, a lot of them are trying to do the same things. Whether they specialize in one thing and then they move into, okay, now we're going to release a scribe product and then we're going to move into RCM, and we're seeing just this kind of convergence of just like platformization of AI. And so what that turns into is, I think you're going to hear ad nauseum, this kind of, you alluded to it earlier, Kyle, but like the orchestration layer that sits on top of the system of record, which is the EHR, that's going to be increasingly important. And whether health systems and providers build that in-house with their own engineering teams or work with partners, the matter is how those AI companies or engineers are differentiated. What data do you have? What switching costs are there? How good of an engineer you are, how much experience do you have in healthcare? Ironically, it's going to be the actual kind of human components of who you work with rather than the technology itself, in my opinion.
Yeah.
So,
okay. All right. Herd, any thoughts for 26?
We haven't talked about it, and we've a little alluded to it, but I still think Medicare and financing of Medicare is going to rear its ugly head at some point. I was reading the Wall Street Journal this weekend talking about Social Security, and I mean, Social Security is running out of money, and we're reaching a point where we're out of money, and we need to do something about it. I can remember when I was a senior in high school 30 years ago, we were talking about Social Security being out of money, and we had 30 years to fix the problem. We haven't fixed the problem, and here we are 30 years later, it's going to be there. Medicare has the same thing, and there's no political willingness to even touch it, but it's going to rear its head at some point. And so I don't know if 26 is the year, 27 is the year, but part of the driver for Medicare Advantage and the lines crossing, like you're saying, is that's one way to try to hold down costs, is put people in managed Medicare as opposed to regular Medicare.
Right.
But that's an issue that's going to have to be addressed.
Yeah, I agree. The only add-on that I would say is we really haven't talked about rural at all today as well. I think rural healthcare, we're going to see more rationalization versus stewardship in my mind. And we've already seen a lot of closures, but unless we get some very creative bedfellows, creative alignment and collaboration, we're going to see more and more of that in 26 as far as just overall rationalization of services or more closures, which I just hate to say. So,
can I pose one more question? We don't have to leave this in, but we've talked a few times about how, the more things change, the more they stay the same. We got a lot of people in here who have been in the industry for a long time. I would be curious, as you guys think over y'all's career, and me being the young buck, I guess, how have you guys actually seen healthcare change? And if so, the answer could be you haven't, but if so, like what areas have you seen it changed, I guess? Putting you on the spot a little bit.
I'd say since I started my career late 90s at Baylor Healthcare System, and I've seen over since that time the health systems get larger. I've seen a bifurcation in healthcare where you have large, well-run mega systems that have been able to solve the profitability problems by branching out and finding profitable areas to manage that margin, to subsidize the unprofitable areas. And I've seen that, and just the amount of consolidation and the amount of the size and scale has gotten bigger. You've seen that along with the continued, the haves and have-nots. Then you see a lot more rural shutting down, challenges of access to care, et cetera. So sort of what you've talked about. I've seen that and kind of lived that over the last 30 years.
For me, I always tell young people, I say healthcare is a great industry to go into. And you know why? Because it's so screwed up, it breeds a lot of opportunity. And so I wish, Clete, we could say, boy, we just need to clean it up and simplify it, because at the end of the day, it's between a provider and a patient that needs a connection and a fix, or a long-term working relationship together. That's the beauty of what we do, is that relationship is very sacred, and it's still there today. But with the system that we have in place, it is a mess. But the river continues to flow, and there's great opportunities in healthcare, and we just need to continue to work towards, finding what solutions are to ultimately provide that care to that patient. So,
I guess I would say, as an imaging guy, when I started, probably MRI, I don't think even existed. So the technology is insane, and I think it's going to accelerate. They're going to figure out, they're going to have it's interesting, the amount, just being around cardiologists, how much they don't know about the heart, and the same with neurosurgeons. But we're going to get so much information about the heart and the brain, and figuring out this dementia, Alzheimer's, and cardiac stuff, and then these enhanced blood tests.
We don't even mention genetics or any of that.
Yeah, I mean, it's there's stuff out there that I've seen that people have tried to connect with us and go, man, this is we can commercialize this. This is going to be off the chart. But
yeah, I agree.
But having said that, it's everybody should go back and eat like we ate in the 50s.
Gosh, I don't know. I could talk about a lot of different topics. I guess what I would say that I think is so interesting is the payer dynamic of, we've had discussions of, should we be a one payer? Should we be socialized medicine? And I guess I would say with Medicare Advantage, we've reversed course and gone the exact opposite direction, and put more of the money in the hands of a commercial organization. And I think that's really interesting to see how that's impacted our world. If you look 20, 30 years ago, there were insurance products, but they were truly stop-loss, catastrophic products. And so now in managed care, I don't go to see a doctor unless I know it's going to be a $10 copay. And so I think the way that we get our care and who is really governing who we get our care from, I think most physicians would tell you it's insurance that has changed everything. But of course, I'm usually coming at it from a physician angle. So
does that help, Blake?
That's very helpful. Yeah. Because just for me, it's like, I could go back and as a writer, I can see what I wrote 2 years ago. And in the grand scheme of things, that's like no time in healthcare, but it's very I could probably publish it tomorrow. People would be like, oh, it's great insight.
That's right.
So
that's right.
Yeah.
All right. Well, thanks everybody for being with us. Great year in review and kind of thoughts on 26. So appreciate you guys being with us again, and best of luck to all of us in 26.
Yeah, here's 26.
Likewise.
Thanks everybody.
Thank you.
Let's get after it.